Good evening. Good evening, everyone. So nice to see such a wonderful crowd out on an October evening. Thank you for coming. My name is Judy Peterson, and I'm very honored to be your president and CEO of your Visiting Nurse Association, the VNA of Chittenden and Grand Isle counties. It's a pleasure to welcome you here this evening with Dr. Lauge Sokol-Hessner. This has been made possible by the VNA's Madison-Deane initiative. For more than 18 years, MDI, as we like to call it, has led our way in this community on the subject of hospice and palliative care. And they've done it through education, collaboration, and inspiration for all of us. MDI's remarkable ability to remain relevant and always looking forward is really testament to the two founders of MDI, their vision and their commitment. And that's Estelle Deane and Joan Madison. Estelle and Joan, would you let us see where you are? Thank you. Yeah. Thanks so much to both of you for being here tonight and making this kind of event possible. I'd also like to ask the other dedicated members of the MDI Volunteer Council to stand and be recognized or raise hands. Many are already standing because they're at work, still up back. MDI is a program of the VNA's End of Life program, and it's just the perfect complement to all of the other things that the Visiting Nurse Association does for end of life care. We do community hospice home visiting. We also have an inpatient hospice facility, the Vermont Respite House, that I'm sure many of you are familiar with. We provide palliative care services to both adults and children. We have Camp Knock Knock, that is a summer camping experience for bereaved families. And also we have the Noyana Singers, our hospice chorus. So I just want to thank all of those hardworking folks who every day are out there providing these terrific services in our community. I'd also tonight like to acknowledge our partners from the University of Vermont Medical Center who've helped make tonight possible with their support and assistance. Specifically, I'd like to thank the University of Vermont College of Medicine, the Department of Family Medicine, and the University of Vermont Palliative Care Collaborative. Thank them for supporting our event tonight. And now it's my pleasure to introduce you to and to welcome Christine Wernicke. Christine Wernicke is the Vice President of Business Development and Marketing at the Visiting Nurse Association. And Christine has been overseeing our Vermont hospice study that's gone on during this past year, and she's now preparing to share findings from that study and engage our community in the next steps for increasing hospice utilization in Vermont. And tonight's presentation is really that very first step. So thank you, Christine. Welcome.
Thank you, Judy. I've been working on the subject of end-of-life care since I came to VNA, which is close to 5 years ago now, and that's just really in its infancy compared to many of the people that are here tonight that have been working so hard on this for much longer than I. But one of the things that I had hoped for when I began this work is that the topic of death and end-of-life care would become a little bit more easier to talk about. It would be more in the mainstream, more normalized. Well, funny story. So last night, I picked up Lauge and we went to WCIX because he was going to be on the 30. So for some of you that are maybe not TV watchers, the 30 is it's a 30-minute segment prior to the 6 o'clock evening news, and they have like a short little segments. So we were waiting our turn, we got there, and some of the other guests of the show were coming, and we were sort of sitting in the little lobby area. And then up on the screen, as we were waiting, came the lineup for the 30. And the lineup went as this: Halloween week, Teacher of the Year, and End-of-Life communication. And I looked at Lauge and I said, oh, this is kind of, he's from Boston. I said, this is sort of our small town, and we sort of put this stuff together. And I was sort of apologizing. He goes, no, that's great. If you can fit end-of-life communication with Halloween week and Teacher of the Year, we've made some progress. So I loved that perspective, and I think you're going to hear a lot more of that from him tonight, this great, fantastic perspective. But I was thinking, like, wow, that is great. And one of the things that was great is he was the first guest. So we led with end-of-life care communication, followed by Teacher of the Year. So last year, many of you attended MDI's fall community presentation that was made by Stephen Kiernan. And Stephen's message that evening was extremely clear. We need to provide hospice to more Vermonters. This was driven by the fact that Vermont was then ranked 48th in the country for hospice utilization. Many people found that news. Some people in the audience didn't know that. Vermont is a leader in many things, so we assumed that we were a leader there. But hospice use is particularly low in Vermont. His goal was to raise awareness of this as a significant problem and issue a call to action to change it. Many of the people in the organizations that are represented in this room did just that and are continuing to do that now. In fact, since that presentation, the most recent data now places us at 46th, so we've moved a couple of points. And many hospices, including our own VNA of Chittenden and Grand Isle County, are reporting growth in their programs. In fact, our own VNA is up just over 13% in the first quarter of this year compared to last year in hospice census. So this is the result of setting goals to increase hospice use, expanding efforts to raise awareness, and increasing outreach and education for providers and the community. So that's great. We've done a lot of that, but having a focus on the problem is not enough. When something else is going to need our attention, we'll shift our focus, and inevitably, the system is left unchanged. So what do we need? We needed a better understanding of the problem. Our resources in Vermont are limited, and so we needed to know where to put those resources in a way that they're going to be most efficient and effective. So, once again, the Madison-Deane initiative as leaders in end-of-life care steps up, and with additional support from VNAs of Vermont and a grant from the Coveris Community Health Foundation, we commissioned a study to explore hospice use in Vermont and gain a deeper understanding of the barriers that Vermonters face. That full report and a community presentation of the findings are planned for November 10th in Montpelier, and in your program there are details on that presentation. And you can also find more information on VNA's website at vnacares.org. But I want to share a few of those findings because they'll provide an important context for tonight's presentation. First, we confirm that there are a combination of factors that are contributing to lower use. It's not just one thing. That would be nice, but it's not one thing. There are many things happening. That said, addressing those challenges is within our reach. We also learned that even though Vermont is a small state, we cannot paint it with one broad brush. When we looked at data, hospice use across Vermont varies dramatically from region to region, in a large way. However, given our small population size, even regions with higher use of hospice are not large enough to bring the state rate closer to the national average. So we have a numbers problem. More specifically, though, the study reveals, one, the importance of consistent communication in all care settings. So as we think about the seriously ill patient and they're moving through many care settings, it's important that they have ready access to this information about options, and that information is consistent. For patients and families, they need resources and materials describing hospice services, especially including how it works, how it is paid for, and where you can receive care. There's one quote in the study that one of the biggest concerns for Vermonters when, after they've heard about the diagnosis, is how they're going to pay for the care. And many people don't know that hospice is provided through the Medicare benefit, most other benefits, does not have any copay or any other cost. For physicians and direct healthcare providers, training and education on the difference between palliative care and hospice was asked for. We talked to over 70 physicians across Vermont, and consistently across the board, that was a need. Having the ability and training to have more conversations, and how to have those, when to have those, and who to have them with. And a big one is prognostication, how to determine eligibility for hospice. Some additional training and information on that and support in making that happen. We also heard that the role of relationships and how relationships play out in hospice referrals was highlighted particularly. That may sound like an obvious thing, but really understanding what that means was helpful, particularly the availability of professional palliative care and hospice providers as go-to resources for those referring providers. When there were communities where it had strong champions, the palliative care teams in hospitals, hospice medical directors that were available and worked closely with their colleagues as referring providers, the providers said that it was easier, and they had that go-to resource for consultation. So that relationship, that peer-to-peer relationship, determining whose role it is to have the conversation with the patient. Patients with serious illness encounter multiple physicians, each with a different relationship to the patient and to that patient's care. And Lauge is going to talk a little bit about what they see at his hospital tonight, and can talk and maybe address some of that for us. But particularly, we heard that hospitalists feel that they see this patient for a little while, but it's the primary care physician that owns having that conversation. Whose role is it to have the conversation? When, why, and what conversation should that be? It's complicated. There's a lot that's happening there. And relationships between hospice and other caregivers. At the end of the day, the people that are currently caring for individuals truly care. And they don't want to hand off that care relationship to somebody else. So understanding hospice's role, and that it's not competition, but it's the extra layer of support, is a really important thing for us as hospice providers to be able to communicate and to build that relationship with those other caregivers, including nursing homes, private caregivers, and even family members. That's just a snapshot. There's a lot. There's a tremendous amount, and more of it's going to come out in the full report and then a full presentation on November 10th. We invite you to listen, to be a part of that, to be engaged. I want to say that research is used to expand our understanding. It tells us where to look further, but it does not give us the solution. It's not going to tell us how to fix it. We have to figure that out with that data, with that evidence. The final report is going to include findings specific to the scope of the study. It was a large and complex issue, and we couldn't answer all the questions. But a lot of work went into kind of defining what that scope is, and it will focus on answering those. More research is probably needed. The next step will be to engage in a discussion where our resources can be most effective in driving change and what we can do to systemically change our practices. And that brings me to introducing our speaker for tonight. Dr. Lauge Sokol-Hessner was selected by MDI because of his success leading systemic change at Beth Israel Deaconess Medical Center to improve the end-of-life care experience for both patients and physicians. He is a hospitalist, the Associate Director of Inpatient Quality at Beth Israel Deaconess Medical Center, and the Associate Site Director at Beth Israel for the Harvard Medical School Fellowship in Patient Safety and Quality. In addition to caring for a broad variety of patients and their families, his work includes collaborating as a member of interdisciplinary teams, coaching medical students and residents as they develop their communication skills. And I do want to acknowledge there's like a ton of students here tonight. That's so great. I'm loving to see that. In his quality improvement role, he leads several projects, interdisciplinary team training. This is my favorite, preventable emotional harm from disrespect. Love that. And Conversation Ready. He's going to tell you a little bit more about this, a collaborative initiative with the Institute for Healthcare Improvement to improve end-of-life care. Many of you have probably heard of Ellen Goodman's The Conversation Project. Conversation Ready is the sister program to that, and he's going to cover a little bit of that. He's worked in Southern Africa on multiple occasions. He completed his medical school and residency at University of Pennsylvania in Philadelphia, worked as an attending physician at University of Washington Medical Center in Seattle before moving to Boston recently. When not working, he likes to spend time with his family and friends, and welcome to his family tonight, in his garden, running, biking, or hiking in the mountains. On our way here, we were pointing out the mountains, and I said, have you climbed any mountains? He's climbed both Mount Mansfield and Camel's Hump. Yeah? All right, so we get some points there. Lauge, welcome to Vermont, and thank you for coming.
All right. Thank you all, and thank you to the Madison-Deane Initiative for inviting me to speak with you tonight. I'm really excited to share some of what we've been doing in Boston. I recognize that I don't live here, I don't work here, but I had a wonderful opportunity to get to know a number of community members and providers from Vermont before I came, and I think through my work in other settings have some sense of the challenges you face in a state with many rural settings. So I'm hoping that what I share tonight with you offers you some ideas as you begin and continue the work of improving end-of-life care here. I'd like to start actually with a show of hands, if we could, just so I get some sense of where we are. I have the feeling that you're the choir, so to speak. How many of you have preferences for the kind of care you'd want if you got really sick someday or were near the end of your life? Everyone. How many have you talked with your healthcare proxy or your healthcare agent or your family about those wishes? Again, most of you. How many have actually written them down? Good. And how many have talked with your doctor or your healthcare team about those? Not quite as many, right? And so this is the gap, and we know the gap is, especially outside this room when it's not the choir, is large. 90% of people say that talking with their loved ones about end-of-life care is important, but only about 27% or so have actually done so. And if you ask patients with serious illness if they would want to talk to their doctor about end-of-life care, 80% say, yeah, definitely. But less than 10% have actually done so. So this gap is a real problem, and it's really trying to cross this gap that we're working on. Before we talk about that, I want to reflect a little bit on what might make for a respectful end-of-life experience. And this concept of respect is one I'm going to highlight and describe in several different ways tonight, because I think it's been a very powerful message and language to use in our institution. So when I think about several aspects of end-of-life experiences, one is what's the family's role in decision-making? And I ask some patients and they say, oh yeah, no, I want to make all the decisions and then I'll involve my family, because if I involve them from the get-go, that's going to get really complicated. And other patients might say to me, oh no, I defer everything to my family. I want them to make all my decisions. I trust them. And if I go to that family, they say, oh yeah, no, we'll do it. They're the sick one, we're the healthy ones. Why would we burden them with difficult decisions in the time of illness? So what respect means to different people around this aspect of end-of-life care really varies widely. What if we think about symptom control? Pain is a very common feature at the end of life, and the medications we use to treat pain, narcotics often, have the side effect of sedation. They can make folks sleepy. And one patient might say to me, you know, I want to be alert and awake as much as possible so that I can interact with people, because that's what brings me joy and meaning in my life. Even if I'm in a lot of pain, I want that. And another patient might say, I can't take this pain anymore. I want you to give me pain medication, even if it makes me sleepy. So even on this metric, what makes for a respectful experience varies widely. And lastly, if we think about use of life-sustaining treatments, this is also tricky. I had a patient recently, Miss S, who was quite sick with metastatic breast cancer. And when she came in the hospital, she very clearly said, I'm not ready to go. I know that there may not be a lot you can do for me, but I really, really want to see my granddaughter get married. And it's happening in a few weeks. And that would mean the world to me if I could make it to that. I'm willing to go through a lot to make it to that. Whereas another patient I had recently, Mr. L, elderly gentleman passing from metastatic lung cancer, said to me, you know what, I've lived a full life. You're telling me my time is short. Thank you for telling me that. I'm ready to go. There's nothing else I need to do to feel that I've had the chance to complete my life the way I want. And so again, it varies widely. And what I take away from this is that one size definitely does not fit all in terms of end-of-life care. But what I do think fits is the approach of asking what matters most so that we can respect it. That's really something we can standardize and can take towards everyone. And so tonight, that's what I want to talk about, is this focus on respect and how we can get to that. Healthcare institutions, how they can shape systems around respect, because I think this is a major piece of the work, is making it systematic and building it into our care systems, not just something we do on top of them. And then ending with talking about patients and providers, expanded from just physicians, but really providers, because it's everyone who's involved in the care team, and how we can strengthen those relationships through conversations that are based on respect. A few terms that I wanted to just highlight before I begin. Provider, I'm really referring to anyone on the care team, so physicians, nurses, nurse practitioners, social workers, chaplains, anyone who's involved in the care of the patient. Family, I'm referring to anyone who the patient wants involved in their care, regardless of whether they are biologically or legally related. Proxy is the colloquial term for the healthcare agent in Massachusetts, so I hope you'll pardon me as I use that term commonly tonight. It really refers to whomever the patient wants us to be speaking to if they're ever unable to speak by themselves. And MOLST is the Medical Orders for Life-Sustaining Treatment form. It's the similar form that you have here, the DNR COLST form. It's our version of that. It's essentially an order from one clinician to another about a patient's preferences about end-of-life care. So we'll come back to those terms in a bit. So why focus on respect? Why are we choosing this as our frame at Beth Israel Deaconess Medical Center? Fundamentally, I think it's about finding the right message to be able to harness consensus. It's not that we haven't been trying to get better at end-of-life care for years. We have. But we haven't been able to get traction. We have so many different people and interests and stakeholders where we work that we needed to find a message that engaged all of them if we were truly going to make systemic change. And so I want to try and convince you of that tonight and why we found that so valuable. And I want to do that by exploring a few of the different messages that often get brought up when we think about end-of-life care. One of them that we often start with is that end-of-life care costs too much. And indeed, perhaps it does. We know that significant proportion of Medicare expenditure is within the last year of life. There's a lot of talk about this. But also, as we know, when you add fear to that, it leads to the death panel conversation. And unfortunately, I think that conversation set us back a few years as a country. We couldn't rationally talk about this because everyone was feared there would be a room of people somewhere that would decide who got what kind of care. And that fundamentally was a non-starter. We've had to learn how to work through this message. The cry that came up was, "You're pulling the plug on grandma." Right? It's pretty inflammatory, pretty difficult to come back to that. And we've had to learn from very wise folks, Ellen Goodman, who's involved in creating the Conversation Project, and Lachlan Foro, who you'll see a little bit later tonight, both coming up with messages to help us reframe this, including this is really about ensuring that grandma or her designee controls the plug. It's actually about giving them back their autonomy. And when the time comes, we often know there is no plug. It's not that everyone at the end of life is hooked up to a life support machine that's in the wall. Having to take the time to walk through these messages and work through them really distracts us from the work of actually getting better. So we wanted to move away from that message. One of the other messages that came up is that people don't come here to be told they're going to die. People say that about our healthcare system. Providers will tell me, this patient with this terrible illness is coming to me because they want to get better. And even if what I have to offer isn't going to help a lot, I want to offer it because that's why they're here, right? And we have to reframe that. And I think The Onion helped us do that a little bit with this wonderful article a few years ago. Despite the enormous efforts of doctors, rescue workers, and other medical professionals worldwide, the global death rate remains constant at 100%. Indeed, America's finest news source. Right, so the fundamental message there is that death is actually a regular and normal part of life, and ignoring it doesn't make it go away. We can't put our head in the sand here. We need to talk about this. And a reframing of that I find really powerful is that deaths are like births. This comes from one of our palliative care providers. They're special times, and we only have one chance to get them right. And we owe it to our patients to do our best with that opportunity. Worse than talking about death is losing the chance to have made the most of life. So let's talk about it and get it right. So with all of this, we've ended up settling on a message that I think does resonate with everybody, and that is let's get everyone to express what matters most to them at the end of life so that we can respect it. Let's work on getting that right, and then let's see where we are. And so it's that message that began the Conversation Project. As you heard mentioned, this was a large initiative started by Ellen Goodman and others in the Institute for Healthcare Improvement, focused on patients and families, trying to get them to express their wishes, to talk about what matters most to them. They have a wonderful web presence and a conversation starter kit. They're involved in social media and traditional media, and are really starting to change the conversation. They try and meet people where they live, work, and pray to get them to start having these conversations. And it's fascinating work. It's great work. But as they began it, they realized that's great if we get everyone to talk about this in the community, patients and families. But if the healthcare system isn't also ready to talk about it, it's not going to translate into meaningful improvements in care. So how do we do that? And that's where this Conversation Ready initiative comes from. And that's what I want to spend the time tonight talking about. This began at the Institute for Healthcare Improvement. Kelly McCutcheon-Adams here directs the project there. It began with 10 pioneer sites. Our hospital was one of those. It expanded to a larger group of hospitals. And for a few years now, we've been trying to learn about how do we do this? How do we get our providers and our institution to be ready to talk about it? So we've talked about the focus on respect. I want to transition now and talk about how healthcare institutions can shape their systems around respect, and how do we actually do that? How do we build respect into our systems? So I'll talk about a number of different things. One is our vision, how we think about this. I want to share with you the allergy analogy, which is a way of thinking about how deeply we want to embed this in our culture. I'll talk about healthcare proxies as one good example of the way we can drive improvement work very systematically. I'll talk about building a culture of respect and how we actually do that with our policies and our approaches. And lastly, putting that all together into the idea of population health management, which is where I'm hoping that we will go with this work. So our vision of advanced care planning, I want to share with you in the context of a patient coming to our hospital. When that patient arrives, they'll establish care, often with an outpatient provider. We'll call them Provider A. And it may be a primary care provider. It may be a specialist. They form a relationship with that person. They get to know them. They talk about their illnesses, their diseases, about what matters most to them and who they are as a person. And that's when this process of advanced care planning can begin. I'll describe it in terms of 4 R's. It's a nice, easy way to remember the process. Reach, record, retrieve, and respect. So that provider can reach out and record some advanced care planning information. First, they can ask, who's your healthcare proxy? Who's your healthcare agent? Who should speak on your behalf if you're ever unable to do so for yourself? And we can put that in the chart in ways that are easily gotten by future providers. They can also start to have some conversations, talking about that illness and what matters most. Now, as these patients progress, it's true that some of us will just die suddenly. But I think most of us are going to develop some sort of serious illness, and that could be organ failure, kidney failure, heart failure. It could be a terminal illness like metastatic cancer, or it could be frailty from older age and repeated hospitalizations. Regardless of what it is, I would argue that that's sort of a trigger or a flag, saying not only is this patient now at increased risk of death, but they're also at risk of complications, difficult decisions down the road. We need to be ready for that. We need to prepare in earnest now. If we haven't already done so, we should reach out and record their proxy and have some conversations about that illness and what the future might hold. And for some of those patients at our hospital, MOLST may be a good option. This idea of a prescription from one clinician to another about life-sustaining treatment. What does this patient want in the setting of an emergency may be a useful and important tool to respect their wishes. Because we know things happen when folks have serious illness. And eventually, every one of us, every one of them, will end up near the end of their life. They'll eventually enter an active dying phase, and eventually they'll die. And what we know from looking at the care in these cases is that it's often provided by Provider B, someone other than Provider A. It could be someone in the emergency department. It could be me as a hospitalist. It could be someone in the intensive care unit. And we don't have a preceding relationship with that patient. Yet we're providing care at these very important times. So how are we going to respect their wishes? So one of the major purposes of advanced care planning, apart from helping the patient and family process all of this information, is so that providers can go back, retrieve the information that was collected, and use it to help ensure that the care they're providing is congruent with that patient's wishes. So this is our vision of what we want to be happening in our system. And this does happen. I think it happens here. It happens in many places. But it doesn't happen as reliably as we would like it to happen. And that's really one of the keys here. It's not that good end-of-life care isn't happening. It's just not happening 100% of the time that it should, or that it can. And so this brings us to the allergy analogy. Now imagine this same patient coming to our hospital and establishing care and then working their way through the healthcare system. Every single time they encounter us, somebody's going to ask them, do you have any allergies to any medications? We're very good at asking that, right? You chuckle because you've been through it and you know how frustrating it is to get asked the same question 3 times in a 1-hour period, right? But that is so much a part of our culture. It's so much a part of how we take care of people that we just don't even think twice about it. And we reliably reach out, ask that question, record the information, and then retrieve it when we're prescribing medicine so that we respect that and don't cause harm. Right? It's just part of how we take care of people. And if we found a patient had gone through part of our system, but we had not done that, we would look back and say, ooh, that's a patient safety issue. That's a medical error. Why didn't we do that? We always do it. What happened? What failed? And we want advanced care planning to be exactly the same as that. So reliable that it's part of how we take care of people. It's not some special different thing. So this is our overall vision, and I want to hone in now on this concept of a healthcare proxy and why that's such an important element. We could talk about the other elements too, but I think this is one where there's really broad consensus, and also we have a lot of good information about it. One of the things that we know is that it's important to have a proxy because it's really common that our patients lose capacity. Of patients 65 and older, when they get admitted to the hospital within 2 days, the first 2 days, about half of them need some sort of surrogate involvement for decision making, and a quarter of them have all of their decisions made by a surrogate. And these are not low-stakes decisions. These are about life-sustaining treatments, about tests or procedures, about discharge planning. My takeaway is that the loss of capacity is highly prevalent, and we really need to be prepared. We know this is going to be happening, and we know it has consequences. We ought to be ready. We ought to have a healthcare proxy for especially anyone who's at risk of losing their capacity. So we asked ourselves, how can we motivate improvement at our hospital? We know that this is an issue anecdotally. We hear of lots of cases. We have M&M cases where patients don't have healthcare proxies, and it leads to real trouble because we're left guessing as to what they would want. So we know we want to get better at this. How can we do that? One of the things I want to share with you now is a video that we actually put together because I think it demonstrates a few things. One, how you can build consensus around a really important idea, and 2, how you can engage your community by telling stories and sharing those stories widely. The people that you'll see in this video include our Chief Quality Officer, our Director of Inpatient Quality, someone from Interpreter Services, nursing, social work, medical education. It's a broad swath of the community. If anyone in our hospital saw this, they would instantly recognize at least one of the people as someone that they know. And so how can we use this? Think about how we can use this to motivate change in the institution.
A healthcare proxy is a person who will make decisions for me about my medical care when I don't have capacity to make those decisions for myself.
Someone you trust.
An advocate, someone who's a voice for your healthcare decision making.
My healthcare proxy is my wife.
My alternate, I've got my best friend.
My healthcare proxy is my mom.
If circumstances change and you want to designate somebody else, you can always change it at any given time.
I think a healthcare proxy is important because one never knows when you might need somebody to be making important decisions on your behalf.
I don't actually have to imagine why it's important. I've actually lived through it, where my dad became very ill, and fortunately a month before we had a conversation about this, and I was his healthcare proxy and had to really carry out some of his wishes. Even though they were very difficult, I was comforted knowing exactly what he wanted to happen.
Mostly when people are talking about their wishes, it's really about what are the things that matter most that would make life worthwhile and make worth living to keep going if you're at a situation where you're uncertain.
That's going to change over time, so these are continuing conversations. When you're 25, what you want to do is different than when you're 85 or 90 years old.
I think it's very important that your doctor and the folks taking care of you know your wishes and know who is delegated to speak for you.
Especially, your primary care physician, he or she definitely should know about it. And if you have a specialist that you see, a heart doctor, or let's say if you're a cancer patient and you see an oncologist, it's important to let all these medical providers know.
When patients don't have a healthcare proxy, we're not always sure exactly what their wishes may be, and it becomes a lot more difficult to make decisions on their behalf.
We have to make assumptions that we we know what's best for the patient. And we do that in a very well-intended way, but we oftentimes don't really understand the context of that patient's lives.
We are anxious to, whenever possible, eliminate that ambiguity and be sure that we are acting in a way that is most consistent with what we know that person would want.
It's important to actually have these conversations when you're healthy and when you have the ability to really express your wishes.
So pre-planning is just much easier for everybody.
So we took that and we wanted to grow our institutional awareness, because we all in this room, I think we know this is important, but we know that the rest of the institution doesn't necessarily. And so we took this video and we shared it widely. It lives on our website. We've played it in a number of settings. We reach out to different areas and use it to tell the story about why a proxy is important. We also have an event every year called Talk Turkey around Thanksgiving. We also hold it at National Healthcare Decisions Day, which is right after Tax Day in April. And we have tables set up in the cafeterias and in the hallways, and we hand out thousands of healthcare proxy forms and encourage staff, providers, patients, families to sign up for a proxy. We also have electronic signs, so big computer screens around the hospital with different messages going through, and now healthcare proxy is part of those screens. We're just trying to make this part of how we infuse our culture with the importance of this work. But I don't think that's good enough, and I think we needed to move towards some data. And I want to show you a little bit of data, because I think that's one of the real keys here. Again, it's not that this work isn't happening. It's not that some patients don't have proxies. They do. It's that not everyone who needs them has them. So we need to identify the gap and then cross that gap. So here's some data. These are the patients seen in a clinic in the Department of Medicine, for instance, cardiology or oncology, during a 1-week period. And what we asked were how many of those patients, what proportion of them had a healthcare proxy. So you can see 3 different colors. The bottom portion of the bar of the graph is green. Those are patients who we had a name and a phone number. They had chosen a healthcare proxy. It's about 40%. An additional 20% on top of that, we had asked them, do you have a proxy? And they said no. And we said, okay, that's fine. Here's some information. We really encourage you. Maybe next time you come back, you could sign up for one. We'd addressed it, but they hadn't yet chosen it. That's the orange piece, about 20% or so. And the top part there, the red, are the proportion of patients who we had never asked and we had no information at all. And what I want to point out to you is this is actually the median in the Department of Medicine. So these are all the clinics in the Department of Medicine, organized from the top performers on the left side to the lowest performers on the right. The clinic on the left has asked over 90% of patients and they've chosen a proxy. They've done their work. Whereas the clinic on the right, less than 20% have actually chosen a proxy. There's a lot of room for improvement there. But without looking at the data, we would never know where to focus. We would never know who to go to say, hey, how are you doing this so well? What is it that you do? And we wouldn't know who to go to and say, how can we help you get better? So we took this and we decided to focus, and we focused on our primary care practice because among the clinics, it's the behemoth. It sees over 42,000 patients a year, over 100,000 visits. It's huge, and if we can make change there, it's going to have a massive impact on these rates overall. So we looked at their data, and their data were similar. 40% or so had chosen a proxy, about 20% we'd asked, but they hadn't chosen one, and another 40% on top of that, the red, we had never asked. And the medical director for that clinic, with her staff, put together an interdisciplinary initiative. Now, when a patient comes into the clinic and doesn't have a healthcare proxy, the medical assistant who rooms the patient provides them the form and tries to convince them why it's important to have a proxy. In fact, they're doing the bulk of the work. When the physician or the nurse practitioner comes in, they reinforce that, but don't necessarily spend a lot of time on it. And when that patient checks out, the administrative assistants at the front desk witness it, give them a copy, make sure the information gets scanned into the record. And that now is a very sustainable part of their work. They do this every single day. It's not some special initiative. They've been doing it over a year now. It's just part of their flow. And so by September of this year, they had done over 1,450 new proxy forms using that process. And when we looked at their data a year after having started, now it's up to 60% have chosen a proxy. Obviously, still a lot of room for improvement, but because this is part of just how they take care of people, that will get better. It will get to where it needs to be. And it's sustainable enough, it's now spreading to the rest of that primary care practice. So just the way we did here with identifying a gap, focusing, making a good initiative, and putting it in place, we want to do that with all the other aspects of advanced care planning and cross those gaps. Another piece of healthcare proxies and about advanced care planning in general that I think is very important is something I learned from Kelly and IHI, which is this concept of exemplifying. If we as providers and staff in the hospitals have actually done the work of advanced care planning for ourselves in our own lives, we're that much better placed to help our patients and their families do this work. So we've conducted these 1-hour interactive workshops where we have folks, I just did this with our entire internal medicine resident class, fill out the proxy form and actually practice planning a conversation with that person. They turn to the colleague and they say, hey, how would you talk about this? What words would you use? What phrases? And we've gotten some good feedback and takeaways that I think speak to the importance of engaging our own workers. So do this across the hospital. It was interactive and practical. It was helpful to learn more about the proxy, and I need to select one. It's never too soon to have the conversation. I need to have it, and maybe best, I need to address proxies more with my patients and have conversations with them. So by really getting down to how do we really do this work, we can improve. So we're taking these ideas of really embedding things like proxy into our culture, and we're now trying to build this culture of respect. One of the things that we've started to do is to look at cases where things don't go well and ask, can we learn from that, and can we prevent that harm from happening again? So I want to share this concept of preventable harm with you. It's a really interesting idea. It's something we've been using at Beth Israel Deaconess for about 7 or 8 years now. And the concept is this, it's that harm happens, so bad things happen in medicine. For instance, infections. We put in big IV catheters into people, we call them central lines, to give them medications, fluids, things like that. And when we put those in, sometimes we introduce infection. That's a form of harm. But some of that harm is actually preventable, not all of it. We can't prevent all of those infections, but we can prevent a good majority of them. And we know that if we clean the skin properly and put sterile drapes up and use proper technique, we can drastically reduce the incidence of infection. This is work that's gone on over the last 15 years or so. And when we can do it, we should do that 100% of the time. We should try and prevent as much harm as we possibly can. So when harm is preventable, do it all the time. And if we don't, then we should be held accountable if that standard of care is not met. So if someone gets an infection from one of these catheters that's in there, we look at the case and we ask, did we do all the things, the standards that we know we should have done to prevent that harm? And if we didn't, that's on us. We should have done that, and we publicly report it, and then we talk about it in the hospital at all different levels, including all the way up to our board level, our quality and safety committees. And so that method has been in place, and I think really engages the institution and providers in ways that they can believe in. A doctor who doesn't follow those steps can go back and say, no, you're right, I really should have done that. I am accountable for that. That was on me. Whereas if we measured every single episode of harm, even the ones that weren't preventable, we would lose some engagement there. And so this approach has worked very well. I want to share a case with you now to try and convince you it's not just these physical harms that matter. So imagine a patient has a type of advanced cancer in her abdomen. When she tries to talk with her cancer doctor about how serious it is, he says, you're not dying from it now. And she feels relieved to hear this. Soon thereafter, she begins to experience problems with nausea, difficulty moving her bowels, and pain. And these symptoms worsen, and she has to go to the hospital. And there they discover that the cancer has caused a bowel obstruction. She's very sick, and she's told she needs emergency surgery or may die. The family requests to see the cancer doctor, but he's unavailable. And instead, one of his colleagues reviews the patient's medical record and speaks with the family, saying, this cancer is not treatable. This is the first time the patient and family have heard this. The patient agrees to the emergency surgery, but suffers complications afterwards, never regains consciousness, and dies in the ICU a few days later. I hate reading this case because it gives me a chill and a cringe, because it's just awful. But I think that those of you that are involved in healthcare know that, unfortunately, occasionally this kind of thing happens. And what I would propose to you in this case is that it's not clear to me that there was physical harm beyond what was already going to occur. This patient was likely to die of their cancer no matter what. But what is clear to me from this is that there was emotional harm or non-physical harm on top of that that seems unnecessary, that seems to have been preventable. And it's really that concept that we're now trying to focus on, which is that preventable harm is not just about physical harm, that emotional harm matters as much as physical harm to patients and families. And I believe that we can actually prevent a lot of that emotional harm, not all of it, but a lot of it, if we are better able to consistently treat our patients and families with respect. Treating them with respect, communicating proactively, will help us prevent those harms. So now when those kinds of harms happen in our hospital, they go through exactly the same process as the physical harms. They get publicly reported, and they get discussed at the board level and everywhere else. It's now becoming part of our culture to treat this with the same rigor with which we treat the physical harms. So it begs the question, well, what does it mean to treat someone with respect at the end of life? What is respect in the context of end-of-life care? And so that, too, we've had to try and build into our systems in the hospital. We're taking this concept of informed consent and expanding it. So I'm assuming all of you have gone through probably some form of informed consent at one point or another. So I'll review it briefly so we can think about how we extend it here. The first bit is that we need to identify folks who are at more than minimal risk. We have to decide who goes through informed consent. Well, it's anyone who we're going to put through something that might have risk. It might be a surgery or a procedure, maybe it's chemotherapy or some other treatment that carries more than minimal risk. There's a chance that when we do this, something bad could happen. And after we identify those folks who are at more than minimal risk, we have to take a standardized approach to respect their autonomy. We have to go through the process of informed consent. We have to say, here are the benefits of doing this. Here are the risks. There's some alternatives. And what questions do you have? I want to make sure that you're making an informed choice about whether or not to go through with this procedure. And this form of conversation, this informed consent process, is something that we've just taken for granted now. We expect that. We expect to be given that chance to respect our autonomy. And we're now extending it to those with serious illness. So Massachusetts passed a law a few years ago. There's some associated Department of Public Health regulations saying we have to do this. We have to identify patients with serious illnesses or conditions that can reasonably be expected to cause their death in the next 12 months. And then we have to require that they're giving information and counseling about end-of-life options. And so now, rather than our informed consent policy just saying it's all about informed consent, it's now our informed consent and decision-making policy. And effectively, it's saying that conversations are an essential part of high-quality care. No longer is it just nice to have these conversations. This is policy. We have to do this to properly care for our patients. So we're trying to put this all together into the frame of population health management. And we want to start by figuring out who are the people that are more than minimal risk. Who are the people that need to really, really have this done? It would be great if everybody had these conversations all the time, but that's hard for a lot of reasons. Let's at least focus on those where we have consensus about they are seriously ill. Who are the group that we all agree ought to be having these conversations? So if we imagine a group of 20 patients out there, just say, who are the people among those 20 that need to have this done? How do we identify them? There are a few different methods that we're working on. One is to use some mortality models, prediction tools. There's a website here, eprognosis.ucsf.edu. If you go and you plug in variables about age and functional status and other things, it will actually tell you the chances of that person dying within the next year or 5 years. It's one way. It's not entirely accurate, but it's out there. That's one method. Another would be to use disease-specific trigger criteria. Maybe it's someone, whoever has a diagnosis of metastatic cancer, they really need to be going through this process. Maybe it's someone who has a chronic lung disease who gets their first prescription for home oxygen. Whatever it may be, we could develop some consensus about those criteria. And lastly, maybe it's just clinician gestalt. There's something called the surprise question, where if I am encountered with a patient, I can ask myself, would I be surprised if this person were to die in the next year? And they've actually studied it, and if I say no, I wouldn't be surprised if they were to die in the next year. That's actually been shown that does mean they have a slightly increased risk of death, somewhat increased risk of death. So which one of these methods we use, I'm not sure. Which combination? Eventually, we'll identify a few people in that group that need to have this work done, that we all agree need to have this work done. And then we have to take some specific actions. We actually have to go through, ensure that they have a proxy, and measure how well we're doing, like I showed you. Have some conversations about their illness and prognosis, their options, which needs to include the full range of options, including palliative care and hospice, what matters most to them, and for some of them, appropriate use of MOLST may be an important tool. And then once we're doing this, we can actually start tracking, measuring, and reflecting. How well are we doing? Because it's not that this work doesn't happen. Again, it is happening. It's that it's not happening as reliably as it needs to, and we need to get to measurement if we're going to identify that gap and focus where the real need is. So that's our system work, and I wanted to share a few lessons learned from that before we transition to the patient-provider piece. One is that removing obstacles, I think, is really essential to large-scale change. A lot of our work in the last couple of years has been identifying why was no progress being made. A couple things we figured out. One was we didn't have a source of truth. In our electronic medical record, there was no place for advanced care planning information except for the name and phone number of a healthcare proxy. We didn't have a place for scanned documents or conversations or advanced directives of other kinds or MOLST forms. We needed to build that. And without that, it was very difficult to get folks to reach, record, and retrieve because there was nowhere to put it. We also had to implement MOLST, so we didn't even have MOLST a few years ago. You guys are ahead of us in that way. So we had to build these tools, these things that we needed, and whatever it is here that you need, those things may be important to build before you really can get to large-scale change. I think also that ongoing progress requires more than this system-level work. A lot of our work has been sitting, creating policy in these systems, but really getting back down to where the work is happening is essential. I think we need to return to where the work is done, and that's what we're now starting to do, go back to the front lines where providers and patients are now trying to figure out how do we actually do this and get back to that and help them work on that. And then keeping pushing. I think we've been at it for 2.5, 3 years now, and now is when other people in the institution are starting to stand up and say, we want to improve proxy rates here. We want to do population health management here. Help us do that. And if we had stopped, if we had not kept pushing, we wouldn't have created those opportunities or now be able to collaborate with them. So we've talked about healthcare institutions and shaping systems around respect. I want to now focus on patients and providers and how we can strengthen these relationships through conversations based on respect. Because I think this is what we are going to encounter a lot in our own work and what really is very challenging to individuals who are caring for patients. So I'll talk about a few different things. One is the hot potato phenomenon and some of the other barriers that keep us from having these conversations. 2 is knowing the process and why it's so important to recognize that it's a process. 3 is the idea of developing respect for the person and why that's such a powerful concept. 4 is finding purpose in caring rather than curing. I think we as providers need to reframe our role, and I'm hoping that patients and families can see our role differently. And lastly, I want to leave you with these guides for providers and patients that were left on your seats, and we'll touch on those briefly. So what is this hot potato phenomenon? What do I mean by that? Well, it's really that nobody really wants to take responsibility for having this conversation. There are a lot of different people involved in the care of a seriously ill patient. Primary care providers, specialty providers, palliative care providers, hospital medicine folks like myself, others including nurses, social workers, chaplains. Who is it among that group that ought to be having this conversation? Many of us turn to the primary care provider, who indeed often has a good relationship and knows the context of that patient's life, but may not know exactly how long they've got with respect to their kidney disease or heart disease, or what treatment options may be available to them. Are they going to offer dialysis or not, for instance? So it may be hard for them to have some of these conversations. A specialty provider, likewise, might say, well, I'm just the kidney doc. I can't talk about the whole patient. I could talk about the kidney, but that's not particularly helpful to a patient. Palliative providers are excellent and have amazing communication skills, but also may struggle with that prognostic and options information, and may not always be available in all settings of care. There's a shortage of palliative providers in many places. And hospital medicine providers like myself have a unique opportunity when someone gets sick, admitted to the hospital. It's a transitional time. We often need to have conversations then, but we also lack that longitudinal relationship, and it may be harder to have some of these conversations. And others are also involved and may have unique roles, and we often, I think, don't turn enough to our interdisciplinary colleagues to have these conversations. Fundamentally, I think what we need to do is develop patient-centered approaches to this problem. This is on us as providers to figure out who's going to take the potato, hold it, and run with it. We need to assign that responsibility. There are ways that we do that now in our healthcare system, but I think it's a call to action for us to figure out how to do this. What are some of the other barriers? And I'll touch on these. There are quite a few different things, and I want to take these, address them, and then put them to the side as we think about how to have these conversations. Time, I think, is one of the biggest. People always say, I don't have time to have these conversations. They take too long. They open cans of worms. It's really difficult. I don't really have a solution for that. I don't think anyone really does, because sometimes these conversations do need to take a while. I think we need to craft systems that allow for that. But I do think there are a couple very specific things we can do to try and mitigate this time factor. One is that we can develop our communication skills, both as patients and families and providers. And I think we need to use our interdisciplinary team more, drawing on our medical assistants, for instance, with our healthcare proxy work, drawing on nurses who can have the conversation. Lots of work to be done there. Payment is another one. A lot of people say, well, I don't get paid to have these conversations. Providers will tell us that. And it's true at some level. So if the patient is relatively well, does not have a serious illness, and you just want to have a nice conversation about advanced care planning, it's true that's not easily covered right now. Medicare is working on it. We're hoping some billing codes come through. But if a patient has a serious illness, we can use the existing counseling and coordination of care codes when greater than 50% of the visit is spent doing that in the context of their serious illness. We can bill for that right now. That's how I do it. That's how palliative care providers do it. We're actively billing in these settings. It's another reason to focus on those consensus serious ill populations and do the work right there before we spread it to everywhere else. Some providers worry about getting dinged for death. They worry about somebody saying, oh, you have a lot of patients that die on your watch. Your mortality metrics don't look good. Providers these days are getting measured constantly on all sorts of things. I, as a hospitalist, at some level, am measured about the rate of readmissions for my patients. How often do they get readmitted after I've discharged them? I'm also measured on my length of stay. I can't really win. If I keep a patient an extra day to try and prevent their readmission, my length of stay is now longer. If I discharge them early to try and shorten my length of stay, their risk of readmission goes up. And I think it's the same for these mortality metrics. It's actually very complex. There are a lot of mortality metrics out there, and some of them actually exclude patients who are on hospice, and others don't. And it depends on which insurance they have and who their payer is, all sorts of things. So it's very complex, and I think my takeaway is we just need to focus on the patient and doing what's right for them rather than worrying about these high-level metrics. And if healthcare system leaders are forcing the metrics on those providers, that needs to be a conversation about why that does not make sense. Some folks worry about repercussions when a patient on hospice lives more than 6 months. They say, I don't know if I want to, I'm not sure if they really are going to, they might live more than that. I don't know if I should enroll them. Is Medicare going to come after me and say I'm committing fraud? The long of the short is no, they won't. If they qualify for hospice when you're enrolling them, that's okay. If they live longer than 6 months, you can recertify them. The hospice agency will take care of that. And if you have doubts when you're trying to enroll someone, just ask that hospice agency, ask the medical director, look at the local coverage determination guidelines, ask for help, because there are ways to figure out if someone's going to qualify or not. So hopefully we can start to spread the message around some of these things and remove some of these barriers or reasons that people say, I'm not going to have the conversation. Once we're able to do that, I think one of the next steps is to say, okay, if we're going to have conversations, let's understand that it's not the conversation, it's a series of them. It's a process over time. And I think both for providers and for patients and families, this is important to realize that it takes time and space to process all this important information. So what are some of the elements? Choosing a proxy is one. Discussing serious news is often the next step. Understanding what matters most to that patient, their goals and hopes, their fears and worries, what trade-offs are they willing to make for the things that matter most to them. Shared decision-making about treatments, helping the patient talk with their proxy and family, and introducing palliative care and hospice, and ultimately maybe introducing and completing a DNR COLST form, just to recognize that these are all different conversations. Trying to have all of these at once would be a really bad idea. It would take forever, and it would be totally overwhelming. So not only can we not do it, we should not do it. We need to give space and time for these things to play out. So understanding that that process exists and understanding the different types of things that need to be discussed can be very helpful. So let's take that now and delve deeper into this patient-provider relationship and how we can strengthen it. You've got a provider, you've got a patient, they're going to have a conversation. The provider might say, let's talk about your illness. And the patient might say, okay, what are my options? They're going to be discussing some content, some medical information, some choices, all of those different pieces of the process that I just talked about. But I propose to you that there's a whole other level of the conversation happening. And that's that the provider's thinking, am I taking away hope? Does this patient trust me? If I tell them their real prognosis, are they going to believe that? And am I going to be hurting them? And the patient might say, do I trust this person? Does she recognize how this will affect my life? When they tell me there aren't any other options to cure my disease, is that really true? And do they get how much this is making things difficult for me? So in addition to the content, there is a relationship and there are emotions that are happening at the same time. And if we're going to have good conversations, we need to focus not just on the content, but on the relationship and the emotions, and we need to learn how to manage those so we can get to better conversations. And that's for both parts, both sides. So respect for the person is one of the ways that I think we can begin to cross that, to manage that relationship and some emotions. And there are a couple different ways I'll describe this. What does respect for the person mean? One way is that patients, I think, deserve and want autonomy. It's un-American not to have autonomy. We all agree on that. 93% want honest answers from their doctors, and 87% want to understand their options. The vast majority of people want the truth. And so in that sense, respect means being honest and sharing the full range of options with them. That's part of respect. Another aspect is remembering that before you're a patient, you're a person. It's not respect for the patient, it's respect for the person. We are fundamentally all people underneath our illness. And if we can discover that person underneath the illness through their values, I think we can form a stronger relationship. And that gets back to this, what are their goals and hopes? What are they aiming for? What are they hoping for? What are their fears and worries, and what trade-offs are they willing to make? Asking these questions, asking the answers to those can really get at values. And I think when we respect those values, that creates alignment because we know we're all headed the same direction, and it builds trust. It pulls us closer together. This concept of purpose and caring, finding purpose and caring rather than curing, I also think is very important. And I think it's based on the knowledge that patients fear abandonment. We fear being left alone when things get really difficult or at the end. There was a nice study asking patients about this and asking them to describe that phenomenon. And one said, "My doctor said there was nothing more he could do. It was a huge abandonment thing." I think we need to reframe the provider's role, and I think we need to see providers differently, and providers need to think of their job a little bit differently. One is we should never say that there's nothing more we can do. We should just strike that from our vocabulary, because it's fundamentally not true. Instead, I think our role more broadly is to alleviate suffering and promote health. And sometimes that means curing and fixing the disease. And when we can do that, we should do that. But we also know that a lot of the time we can't cure and fix. In fact, if our only job was to cure and fix, we would be destined to fail, because we know everyone dies. We need to reframe our role to be about alleviating suffering and promoting health, and always thereby caring even when we cannot cure. As another patient said, "I need to be able to depend on my doctor. They can hold my hand, so to speak, to the very end." That's caring. It's just holding a hand. It's being there. It's being present. It's not abandoning. So I want to leave you with these guides about how we can talk with our patients about serious illness. This one is intended for providers, and I'll touch on just a few of the elements that are in it. One is this idea of 3 quick questions to prepare for future conversations. You'll see it up at the top of the guide there. I really have enjoyed using this with my house staff, the residents and interns and med students that I work with. I think it reframes the conversation in the room in a way that takes about 60 seconds or less. I ask, how much information do you like to know about your medical problems? Do you like to know all the details or just the basics? Where are you on that spectrum? Most folks will say all the details, but not everyone. Some will say, oh, I just want to know the basics. And then I might say, okay, well, who can I talk with about the details? Because there's some important details to talk with. Who's your proxy? Who in your family can I talk with? And make sure that I'm conveying information in the important ways. And then I ask, all right, well, who else? How do you like to make decisions? Who do you involve in your care? Do you make them with your proxy or spouse, other people, other doctors that I need to involve? So I know who needs to be part of that conversation. It helps me prepare. And then lastly, I ask, have you thought about the kind of care you'd want if you got really sick someday? Have you been through the process of advanced care planning at all, is really the question that's behind that. Another big principle that I share in there is called ask, tell, ask. And this is something that I think should be part of all of our conversations with patients. In fact, it's how I greet all the patients when I walk in the room in a hospital. It's how I start the conversation rather than telling them what they need to know for that day. Here, we're going to do this, this, and this. Instead, I start by asking them a question. Would you mind sharing with me where you are with your illness? What's your understanding of what's going on? That way I know where they are and can see if there's a gap between how they perceive things and how I perceive things. And then I can tell them some information and try and close that gap. And I can close at the end by asking, you know, that was great. Thank you for chatting with me today. Would you mind telling me what you're going to take away from today's conversation so that I can ensure we're on the same page? making sure that we've really developed good understanding. Because a good understanding of what's going on right now, where are we, is essential to any further conversation about options. And lastly, I think one thing we do a lot as providers is talk too much. We often have a hard time, especially when we're conveying bad news or serious news. We just want to reassure as much as we can. In fact, what we need to do, I think, is convey the news succinctly and then stop and observe, watch for emotion, and then respond to that emotion. Handle that relationship and emotion part of the conversation before we drive forward with more content. So for patients, I hope that this guide here gives you some insight into the provider's process, helps you understand some of where providers are coming from and ways in which they may approach these issues. I think also useful for patients and families is the Start the Conversation Vermont website. I really have actually enjoyed walking through this and understanding what's in those different pieces, knowing my options, learning about how to start the conversation and making a care plan. It's very practical, useful advice. The Conversation Starter Guide in there is fantastic. And one of the pieces that you've been given tonight is this Preparing to Talk with Your Doctor guide. It gives you some very concrete pointers about before you go to your provider, what are some of the things you should be doing to get ready for that conversation? Things you should think about, ways you can phrase the question, how to help them prepare. So in conclusion, we've talked about this focus on respect and building consensus to facilitate large-scale change and how that's been so successful. Healthcare institutions shaping systems around respect and how building those systems are really necessary to do the right thing for patients. We have to craft our system to support the good work people are trying to do. For patients and providers, how we can strengthen these relationships through conversations based on respect. We can all develop our conversation skills so that we're better at having these conversations, and we can just go out and do them. And now I want to share with you one more story about what this can look like when it all comes together. I think it's a lot to think about how to improve these conversations, but sometimes a very simple question, a very simple focus on respect can help us discover this joy of what it means to respect what matters most to someone. So one final story includes Lachlan Foro, who's our Director of Palliative Care and Ethics Services, as well as one of our internal medicine residents, and a very wonderful and special patient.
Doctors and hospitals really aren't what we call conversation ready, because we ourselves have so medicalized everything that I'm seeing for this patient. What's the dose of this medicine? What's the chemotherapy or not? With this test or not? That we ourselves don't actually often have the experience, the practice, the support that we need to sit down with a patient as a human being, understand what's important to them as a human being, and make sure that that's always at the center of every medical plan. I was asked to see Thelma Patello. All that I knew was she was a 92-year-old woman who had severe vascular circulation problems in her leg, causing her lots of problems, for which there wasn't going to be any effective treatment that they could offer except amputation, which she just refused. She wasn't going to have that done. And so they said she didn't have that long to live, and so they wanted me to come by and maybe talk to her about hospice kind of options.
What I remember, I guess, most strikingly was that Dr. Faro asked her, what would be a good day for you?
And so I sat down on the bed. I said, getting to know you some as a person will help me figure out how I can best help you.
And it's such a simple question. What would be a good day for you? What do you like to do? These things that I don't feel like I have time, honestly, on a daily basis when I'm seeing patients, when I'm on call, to ask these little things.
In whatever time there is ahead for you, how can we make that as good as it possibly can be for you? Singing is what made it a good day.
But it didn't take that long to find out that this is what was important to her.
I said, when was the last time that you sang? And she just sort of said, I haven't sung in a long time. I don't sing anymore. I said, why not? And she kind of looked at me and I said, how about singing me a song?
I see trees of green, red roses too. I see them bloom for me and for you. And I say to myself, what do you say, darling? What a wonderful world. Somebody, where's the drummer?
I see skies of blue.
I see skies of blue.
Clouds of white.
Clouds of white. The bright, blessed sun, and the dark, sacred night. And I think to myself, what a wonderful world. And I think to myself, what a wonderful world. Pop, 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 pop. Oh, yeah.
And it made such a huge difference in her day.
The music was right there as vividly as it had ever been, and every time her voice started to sing, you could just see her eyes getting younger, her face getting younger, and a kind of human joy returning.
Thank you all.
We have time for a few questions, if anyone has any questions for Dr. Lauge.
Microphone coming.
Thank you very much. Why doesn't the insurance industry require every applicant for health care to fill out the form, no matter how old they are? What are they waiting for?
It's a good question. I think, if you don't mind me expanding that a little bit, I think maybe some of what you're getting at is why don't we have systems that really require this work to be done, whether it's through the insurance or something else. And I think that's really what we're trying to work at and work towards, is making this something routine. We, of course, can't force someone to do this work. But I think even if we do it that once, we know that just having the written document, I don't think is enough. I think we need to have a conversation about it. We need to understand the meaning behind that document. It's a very important step, having things written, but talking about it, revisiting it, especially when the context of that person's life changes. What we want now may be very different than if I were to develop a serious illness. So, but that sort of reliability and rigor is what we want to aim for.
Thank you. Is there any mechanism in place or conversation starting with the medical school and medical students to start incorporating this kind of work with all the science that they're studying?
Yeah. The short answer is yes, I think. Could there be more? Probably yes as well. Certainly where I work, there's a course for medical students on how to deliver bad news, where they're taught a very systematic framework. They're actually observed with the standardized patient, and we score them on it. We help coach them through it. So those sorts of things are starting to be done. And I think we can do more to engage them in that.
Any other questions?
Hi. When you were talking about the hot potato and trying to decide who has that conversation with the patient, do you see a role for nursing?
Definitely. So one of the things I didn't talk about tonight is work that's been done by one of our colleagues through the Conversation Ready initiative. So Dr. Kate Lally is the director of the Palliative Care Service at Care New England in Rhode Island, and she has developed the role of a conversation nurse. That's what they call it. It's a nurse with hospice and communication skills training who began in the hospital and at the request of a primary team would go talk to the patients about what matters most to them, what was important to them, and about their options, life-sustaining treatments, resuscitation even. Would try and do it with the primary team to help teach them the skills. If that wasn't possible, she would circle back to them to convey the results of the conversation. She could come back for more conversation if it was needed. And the problem they had was actually needing to add another conversation nurse because the requests on her time were too many. It was something that worked very well in their culture. Whether that will work everywhere, I don't know, but I think the idea of using the interdisciplinary team, drawing on the expertise that exists there, is something we ought to do a lot more. I think it'll be a real key in getting these conversations to happen. Yeah.
One more question here.
Are the words mulched and colched mean something different or mean the same thing as something we call something different in Vermont? I'm sorry to be.
No, exactly. And, so the MOLST form is the Massachusetts version of the DNR COLST. It's just, there's a lot of different acronyms out there, but the essential gist is a form that says if someone suffers a cardiac arrest, what do I do? If they have a respiratory distress episode, what do I do? Should they go back to the hospital, yes or no? It's kind of I think of it as a prescription about life-sustaining treatment filled out by a clinician directed towards another clinician. So, yeah.
Any other? One more? Okay. And the form in Vermont is the COLST.
That's right.
Thank you for your talk. I've worked as a professional guardian in the community, and I see that there's a lot of confusion about where palliative care starts. How would you address that?
Yeah, I think palliative care, to me, as just a concept, is just good medicine. It's attending to patients' symptoms and psychosocial support and bereavement and other aspects of care. It's become its own specialty because we knew we needed to focus on it, and it's a unique skill set that I think requires real training and expertise to be really good at it. But what we know is that there aren't going to be enough palliative providers to care for everyone who has serious illness, and so there's this concept of primary palliative care, where people who care for folks with serious illness need to develop their own palliative care skills and draw on a specialist, a palliative care specialist in special situations. So I really think palliative care should begin with a serious illness, with the diagnosis of a serious illness. And the data that are out there suggest that the earlier is better, basically. Why ignore the quality of life? Why ignore suffering that's not being addressed until it's late in the game? Why don't we just start it early?
Great. Thank you, Doctor.
Thank you.
Thank you, Lauge, for sharing your knowledge and experience with us tonight. You've inspired all of us to improve our communication skills around end-of-life care for ourselves and for others. And thank all of you for coming tonight. Just seeing the number of you here encourages us at MDI to continue our Knowledge is Power programs so that we can all learn together. Just a reminder, outside in the back, if you didn't pick up an advanced directive booklet or Start the Conversation, they're out there as well. And in closing, I'd like to share a poem. It's a short poem that is used in hospice sometimes to send you forth. Go well into life now. What days, what weeks, what months might be. Go well into life now, the joy and hurts of all its moods. Go well into life now, and when you need us, always know that here you will find the hands of friends. So good evening and thank you and safe travel. God bless.
All right. Thanks. Good. Thank you. Thank you. Thank you. Thank you. Thank you. Thank you. It's really fun. Turn this off.